Aortic regurgitation. Backflow of blood from the aorta into the left ventricle during diastole arises due to aortic root dilation, for example, syphilitic aneurysm and aortic dissection, or valve damage, for example, infectious endocarditis. Most common cause is isolated root dilation. Clinical features include early blowing, diastolic murmur, hyperdynamic circulation due to increased pulse pressure. Pulse pressure is the difference between systolic and diastolic pressures. Diastolic pressure decreases due to regurgitation, while systolic pressure increases due to increased stroke volume. Presents with bounding pulse, water hammer pulse, pulsating nail bed, and head bobbing. Results in IV dilation and eccentric hypertrophy due to volume overload. Treatment is valve replacement once LV dysfunction develops. Mitral valve prolapse. Ballooning of mitral valve into the left atrium during systole, seen in 2 to 3% of US adults. Due to myxoid degeneration, accumulation of ground substance of the valve make it floppy. Etiology is unknown, may be seen in Marfan syndrome or Ehlers-Danlos syndrome. Presents with an incidental mild systolic click followed by regurgitation murmur, usually asymptomatic. Click and murmur becomes louder with squatting, increased systolic resistance, decreased left ventricle emptying. Complications are rare but include infectious endocarditis, arrhythmia, sware, mitral regurgitation. Treatment is valve replacement. Mitral regurgitation. Reflux of blood from the left ventricle into the left atrium during systole usually arises as a complication of mitral valve prolapse. Other causes include IV dilatation, left-sided cardiac failure, infective endocarditis, acute rheumatic heart disease, and papillary muscle rupture after a myocardial infarction. Clinical feature: holosystolic blowing murmur, louder with squatting, increased systemic resistance, decreases left ventricular emptying and expiration, increased return to left atrium. Results in volume overload and left-sided heart failure. Mitral stenosis, narrowing of the mitral valve orifice, usually due to chronic rheumatic valve disease. Clinical feature: opening snap followed by diastolic rumble. Volume overload leads to dilatation of the left atrium, resulting in pulmonary congestion with edema and alveolar hemorrhage, pulmonary hypertension, and eventual right-sided heart failure. Atrial fibrillation with associated risk for mural thrombi. Endocarditis. Inflammation of endocardium that lines the surface of cardiac valves, usually due to bacterial infection. Streptococcus viridans is the most common overall cause. It is a low virulence organism that infects previously damaged valves, for example, chronic rheumatic heart disease and mitral valve prolapse. Results in small vegetation that do not destroy the valve. Damaged endocardial surface develop thrombotic vegetation. Transient bacteremia leads to trapping of bacteria in the vegetation. Prophylactic antibodies decrease risk of endocarditis. Staph aureus is the most common cause in IV drug abusers. High virulence organism results in large vegetation that destroy the valve. Staph epidermidis is associated with endocarditis of prostatic valve. Staph bovis is associated with endocarditis in patients with underlying colorectal carcinoma. HEC organisms are associated with endocarditis with negative blood cultures. Clinical features are fever, murmur, Janvalians, anemia of chronic disease. Lab findings: positive blood culture, anemia of chronic disease, transesophageal echocardiogram is useful. Non-bacterial thrombotic endocarditis due to sterile vegetation that arise in association with hypercoagulable state or underlying adenocarcinoma.